Hi, my name is Kim Cornelius, and this is my presentation for my nursing capstone for Dr. Hensley, fall 2019. For my presentation, I chose stroke recognition and prevention, highlighting the risk factors, signs and symptoms, and educational standards for monitoring of potential stroke patients. Before we get started on the PowerPoint, I would like to address the questions at the beginning of the rubric. For my practicum setting, I chose a level 1 trauma center. So in order to get started, I met with Ms. Kim Ferris, the education coordinator here, and received an introduction on an existing project that she had in the works. That project is carotid intervention, focusing on neuro assessments of carotid endarterectomy patients, both pre and post-operatively. To begin, I searched for literature in the medical center library. I also located some educational materials in the Don and Kathy Jacobs Health Education Library on the first floor. I received an introduction to the CRAMES database and also an introduction to the pre-op and PACU settings. Again, this is a level 1 trauma center. There are approximately 80 plus surgical cases performed here each day, Monday through Friday. However, this center is actually open 24 hours a day, 7 days a week, 365 days a year. The pre-op and PACU areas are 2 large neighboring units that consist of 77 patient beds. And the staff in these areas are responsible for a diversity of patient types, including pre and post-surgery, ICU bed holds, floor crashes, boarders, etc. For my specific learning objective, I chose to learn how we assess carotid endarterectomy patients both pre and post-operatively. Where do we stand as an institution on how we educate our nurses regarding these assessments? And what practices are in place and how are they evolving? In the efforts of answering these questions, I met a lot of professionals along the way, and I spent a lot of time observing nurses in action. With the help of Ms. Ferris, I was introduced to just how large of a project this truly is. It not only encompasses the education department, but it's also a multi-professional team that extends enterprise-wide. For this project, a questionnaire was developed to determine a baseline pre-teaching and will be administered again post-teaching to determine if the teaching was successful. While completing my practicum hours, I was able to see the NIH stroke assessment in action, which was interesting for me. You have to be trained in order to perform the assessment on patients. I have not been trained, so this was a nice thing for me to be able to witness. The rationale behind the assessment is that patients may have pre-existing deficits that need to be explored and need to be documented. A baseline needs to be established, and in this instance is established pre-operatively. The patient is then handed off to the operating room. The operating room nurse is responsible for calling report to the PACU nurse or the ICU nurse, whichever area is deemed appropriate for that patient post-surgery. The nurse that continues the care of that patient is responsible for performing a post-operative assessment and comparing that to the pre-established baseline. To reference the literature for a moment, studies published by the Association of Anesthetists of Great Britain and Ireland profess a significant decrease in negative post-operative outcomes and a reduction in the length of patient stay when thorough pre-op assessments are combined with a follow-through in the delivery of care. We're ingrained in assessments in nursing school, so this literature supports that. Also in the literature, according to Latanzi et al. In 2017, significant benefits in neurocognitive function were observed in patients who presented with a more pronounced preoperative impairment. But how do you know that if you don't establish a baseline? The NIH stroke scale that was originated by the American Heart Association is a valid tool in recognizing stroke severity, but this tool can also be used in clinical practice. In looking at the literature, it seems possible that cognitive function of carotid endarterectomy patients can be improved by surgical repair. But how can we measure the benefits in this patient population if we don't establish a baseline and if we don't perform pre- and post-operative assessments? There's definitely a need for more literature and more studies on this topic. However, that is difficult to achieve without sham surgery. Again, in the literature, it was noted that the American population is severely undereducated in the knowledge of the warning signs and symptoms for stroke. This is a level 1 trauma center. Again, it is a large institution. It services a very large patient population, a very diverse population as well. So patients need assistance finding the resources that they need. The Don and Kathy Jacobs Health Education Library is a great resource for patients and families, and also the CRAMES database includes printable patient teaching handouts that they can take home. In regards to the best practices on this topic, there is a lot of positive work being done at this institution. There's emphasis being placed on all carotid endarterectomy patients on assessments pre and post-operatively, and these assessments extend to carotid artery stent and thrombectomy patients as well, which is fantastic because we're basically improving the quality of care to a larger number of patients. It does require a multi-professional team that extends enterprise-wide, and this is definitely a large enterprise with a lot of patients and a lot of employees to consider each day. This is a stroke accredited institution. The stroke coordinator here at this institution has an enormous role, not only in the educating of staff, but also in regard to patient safety as well. Patient charts are regularly audited. Specific unit education takes place when deficits are noted. The staff here are trained every 2 years on the NIH stroke scale, and there are also required yearly web-based trainings. One goal of this project is to close the gap between contract employees and nurses of different experience levels, bringing them up to par for what is expected for this institution. A result of this project is a new badge buddy, and nurses love badge buddies. I have several myself. Nurses can attach this badge buddy to their existing badge and use it to ensure that enhanced neuro assessments, vital signs, and wound and dressing checks are being performed on patients per protocol. A reflection of the personal effect of practicum, first and foremost, I have a greater respect for instructors and educators that have to create these PowerPoints and develop these presentations. It has truly been a challenge for me personally. I'm pretty sure I have recorded this 1,000 times. But in all seriousness, this is a topic that I am personally passionate about. My grandmother actually had a stroke in her 70s, fortunately without deficit. But in the years preceding her death, she began having recurrent TIAs. So this is something that is personally interesting to me. This practicum allowed me to learn more about the NIH stroke assessment, and I was able to actually see that in action, which was a positive experience for me. I also was afforded access to areas that I normally don't get to experience in my personal practice. A project of this size at an enterprise this large might seem like a daunting task, but the multi-professional team that's in place here makes it seem effortless and logical every step of the way. I've achieved a greater appreciation for the education department and see just how much input comes from various areas and other departments in order to achieve a goal this large. The amount of teamwork that goes into ensuring proper communication between units is truly impressive. I mentioned perioperative services only in my project, but realistically this project is quite large. It is an integration of staff nurses, educators, coordinators, directors, you name it, everyone is involved. Our success on these projects directly affects the patient who is at the center of our care. So onto the PowerPoint. This is stroke recognition and prevention. We want to highlight the risk factors, signs and symptoms, and educational standards for monitoring for potential stroke patients. The significance of the problem. This information was compiled from the American Heart Association in 2017. And as you can see here, in that year, it was estimated that roughly 795,000 Americans would have a new or recurrent stroke that year, with 129,000 of those potentially not surviving. Cardiovascular accident is ranked as the number 5 cause of death, and we are all painfully familiar with the amount of serious and long-term disability that it can cause. Again, roughly half of Americans are unfamiliar with the warning signs of stroke, so that's where we as nurses can step in and do a little better job on our patient and family teaching. To highlight some things from the literature summary, we discussed earlier that the NIH stroke assessment was a valid tool in the recognition of stroke severity, but there is evidence to suggest that it can also detect changes in patients over time. Watanabe also goes on to explain that carotid stenosis is likely to result in ischemic stroke and impairment of cognition, and that carotid endarterectomy has proven itself effective in decreasing that future risk of stroke. In a study performed by Latanzi et al. In 2017, it was noted that patients 6 months post-carotid endarterectomy presented with enhanced cognitive performance in comparison to their preoperative assessments. How do you know this if you don't perform those preoperative assessments? So it could be noted that carotid endarterectomy may offer more to patients than just prevention of stroke and also improve their cognitive function. So to understand stroke a little better, we need to look at the physiology. Stroke affects the arteries that lead to and are found within the brain. So when one of those vessels is blocked by a clot or a clot ruptures, excuse me, the part of the brain that is affected doesn't get the blood and the oxygen that it needs. As time passes, that part of the brain starts to die. So when the brain starts to die because of lack of perfusion, the part of the body that damaged area of brain controls is negatively affected. There are two types of stroke: an ischemic stroke, in which an artery is blocked by a clot, and then a hemorrhagic stroke where there is a rupture of blood vessels. These can be seen on the next slide. As you can see here, this is the ischemic stroke. That is the area of the brain that is dying due to lack of perfusion. This is a hemorrhagic stroke where there's been a rupture of blood vessels and the blood is spilling out into the surrounding tissue. Understanding the stroke risk factors, again from the American Heart Association, a lot of these we expect. Hypertension, smoking, diabetes, hyperlipidemia, increasing age. But I'd also like for you to notice sedentary lifestyle, certain blood disorders, excessive alcohol, and abuse of illegal drugs. Some of these risk factors cannot be controlled. For example, increasing age, hereditary, sex, race, and history of a prior stroke. What we can focus on as nurses is helping our patients with these risk factors that can be modified, treated, or controlled. The importance of taking their blood pressure medicine, checking their blood glucose, and taking their insulin. But also these that require a lifestyle change. Again, we can help patients and families find the appropriate resources in case they're interested in cessation of tobacco or alcohol or illicit drugs, or if they just need to simply speak to a nutritionist about their diet, or maybe find assistance getting into an exercise program. The symptoms of a stroke: sudden numbness or weakness of the face, arm, leg, especially on one side, sudden confusion, trouble speaking, trouble with vision, loss of balance or coordination. A lot of people may describe a headache of unknown origin, maybe the worst of their life. These are all symptoms of a stroke. That leads us to the BFAST acronym. Nurses love this acronym. It's easy for us to remember. It's very simply laid out, so it's easy for us to teach to our patients, and it's easy for them to understand. Balance, eyes, face, arms, speech, and time. I would like to emphasize time here. If that's the one thing that patients can take away, is that if you notice the warning signs for a stroke, T is the time to call for 911. As healthcare providers, we know that time equals brain. Carotid artery blockage or stenosis is when the carotid arteries, the vessels, the large vessels that carries blood and oxygen to the brain, they can narrow over time. And this can be due to health issues, influencing factors, increasing age. In a normal carotid artery, it should be patent and the walls should be smooth, allowing blood to flow there to the brain. Influencing factors, including high blood pressure, smoking, and diabetes, can cause the artery walls to become rough, and this allows cholesterol to build up. When this occurs, blood clots can stick to the plaque, and when a clot breaks off, that's when a stroke occurs. This is the NIH neurological assessment. As you can see, there are 11 domains, including sensory, language, speech, and vision. These are graded 0 to 2, 0 to 3, and 0 to 4, with a total score of 42. And as you can see here, this is where you can rate your stroke severity. These next two slides are very exciting. These are the monitoring standards for stroke patients as determined by this institution. You can see here there's carotid endarterectomy patients, TPA patients, and here are the vital signs, enhanced neuro checks, and wound and dressing checks that we discussed earlier that are going to show up on that new badge buddy that's coming out. So these two slides have a lot of information here on when the protocols for when those checks are supposed to occur. And if you're interested in checking those out, the site there is at the bottom of both slides. Patient and family education, as we discussed earlier, as nurses, this is one of our biggest jobs. So we need to encourage our patients to take their medications as directed, to not skip doses. Don't stop taking your medication because you start feeling better. Also, emphasize the importance of follow-up and as-needed appointments with their provider. Patient may not be feeling well, but it's not time for their appointment. We need to ensure that they know that it's okay to contact their provider and let their provider make that call. We need to educate our patients on the risk factors of stroke and again help them find the appropriate resources in order to help them decrease those existing risks. We need to teach patients and families the warning signs of TIAs and strokes and ensure that patients and family members know what to do if they recognize any of those warning signs. Again, that BFAST acronym, that is another patient tool that's great to pass on. Again, this is Stroke Recognition and Prevention. My name is Kim Cornelius, and I thank you for listening.